ahead and get started with our survivorship committee meeting. Thanks to all of you for attending. And on behalf of Dr. Melinda Irwin and myself, thank you so much for attending. If we go to the next slide, you can see that we have not much in the way of disclosures. I have some research funding that goes to my institution. And we can go to the next slide, which we like at the beginning of each of these meetings to kind of remind everybody of the priorities of our committee. Before I do that, I would like to acknowledge some of the other people involved with the committee leadership. And a special thank you to Sandy Hita, who is the clinical trials project manager, who's also been filling in for Veronica Garcia. So she's been a huge help to us. And then as far as other committee leadership, Catherine Guthrie is our statistician, Catherine Crew is our executive officer, and Lee Jones is our patient liaison. So we appreciate all the work that all of these individuals have been doing. Back to kind of the areas of interest of this committee, we are looking to prevent long-term effects of treatment, including cardiovascular complications. We like to address fertility and sexual concerns in our cancer survivors and aim to get a better understanding of immunotherapy-related toxicity. We're also interested in reducing comorbidity in our cancer survivors, and this includes through behavioral research, really to enhance outcomes for this population. And then other areas of interest include reducing health disparities, use of mHealth and technology for care delivery. And we also have an interest in expanding to populations that have been understudied in the traditional survivorship arena. So I'd like to go to the next slide and pass this over to Melinda, who will introduce our wonderful speaker for today.
Thank you, Hallie. I am delighted to present our speaker today, Dr. Catherine Alfano, who is an international leader in cancer survivorship and cancer rehabilitation. She has served as the Deputy Director of the National Cancer Institute's Office of Cancer Survivorship, where she created funding opportunity announcements to fill gaps in cancer survivorship and transdisciplinary research. She also served as Vice President of Survivorship at the American Cancer Society, where she provided vision and leadership to the ACS in regards to research programming and policy efforts nationwide to improve the lives of cancer survivors. Currently, she is at Northwell Health, where she leads both the clinical care design and research across the health system. And operationally, she develops and oversees the implementation and integration of high quality cancer survivorship research and programs for the health system. Her research herself is focused on speeding the effective translation of research into practice and informing policy to optimize patient outcomes. And in addition to her role at Northwell, she has also led work with the American Society of Clinical Oncology to help American healthcare systems develop risk and need stratified survivorship care. We have no one better to speak to us today about the current landscape and future direction of cancer survivorship research. So I'm delighted, Dr. Alfano, to have you here, and I'm going to turn it over to you. Thank you.
Wonderful. Thank you, Dr. Irwin and Dr. Moore, for asking me to be here with you. It's so nice to be among friends. Let me get my screen shared here. All right. So what I want to talk to you all today is about the role of a learning healthcare system in oncology and really how it can be used to personalize care, improve value in our care, and facilitate research. And I've put this image of a bridge up here because really, like a bridge, a learning healthcare system for oncology is a two-way entity. Right? So we're speeding the translation of evidence to practice, and we're collecting data on practice insights that feeds back into better research questions. And I'll tell you all more about that as we get going on. So First, I always like to start with the presenting problem. And the presenting problem here is really that oncology has to navigate what for years I've been calling the perfect storm. It's a confluence of factors that's causing a perfect storm in our inability to provide the kind of care that our patients need. One is just the numbers, right? We've got our new ACS numbers, 1.9 million new patients being diagnosed with cancer every year, joining the nearly 17 million cancer survivors already living in this country. And secondly, we are really seeing the demographics change in terms of who our cancer patients are, with a much bigger burden in older adults and in minorities that have more implications for their healthcare needs. We know, and I know I'm preaching to the choir here, that cancer causes a whole host of chronic and late effects. These are physical problems, psychosocial problems. As a rehabilitation clinician, I'm very worried about people's ability to function in their roles and their work, care for their children, their aging parents, right? And that financial toxicity as well. On top of all of that, we have massive disparities in our outcomes by every social determinant of health imaginable. We're increasingly relying on caregivers in the home for more and more of cancer care and survivorship care, which is taxing our caregivers. We also have provider shortages nationwide. We're doing a lot of arguing about who should be providing cancer survivorship treatment, but really, we don't have enough oncologists, primary care providers, nurses, or any sort of specialists like cancer rehabilitation, palliative care, psychosocial care, any of those specialists that are needed to treat the ongoing needs of cancer survivors. Before COVID, our providers were burning out at higher rates than ever before. Now with COVID, we've got PTSD in our providers. We've got a lot of excess stress. So that's adding to this perfect storm. And on top of all that, no clinician gets enough information about the long-term effects of cancer therapies in school. Not oncology, not primary care, not ACPs, nobody. And then we have spiraling costs of cancer care, excess costs of being a cancer survivor, and all of this needs to change while we're transitioning from fee-for-service to value-based care. And I think with the new political administration in Washington, D.C., we're going to see a lot more discussion of this, especially with the new HHS secretary just confirmed. So what happens? That perfect storm makes our busy clinics feel like this, right? It's like, if you're a clinician in practice right now, you feel like there's this tsunami wave hanging over you all the time. Your waiting room is booked up. Oncology just is completely overwhelmed. And that perfect storm also focuses oncology care from diagnosis forward, just exclusively on treatment, disregarding the impact of that treatment on that patient's ability to function and their quality of life. The problem with that is that patients want us to balance our anti-cancer therapy. They want us to balance tumor response with the ability to enjoy their lives and function in their lives, right? So I've got this balance lifted here. This is what they want from us, but we're not providing it. And we're ignoring function at our own peril, because we know that a patient's ability to function is a major driver, not only of quality of life, but also of downstream healthcare utilization and, of course, of costs. So the other problem we have, and I've, like some of you, have been in survivorship my entire career, and so I'm guilty of this as well, but we tend to use these group statistics to say, oh, cancer survivors on average have this or that problem, and it ignores the fact that there is substantial heterogeneity in our patient populations, right? Where you've got some of our cancer survivors who just cannot get off the couch, and you've got others who are out here running half marathons or marathons. So when I was at the American Cancer Society, my colleagues and I put out a paper in 2019 in CA that was meant to be part of a set of papers that were blueprints for the country. In really, this particular one was how to equitably improve outcomes for cancer survivors and support caregivers. And what we posit to you all in this paper, that the solution is that we have to provide coordinated, comprehensive, and personalized care, so that one size doesn't fit all, in a way that optimizes patient function and outcomes from diagnosis forward, that efficiently uses provider time and controls costs. So what we said in this blueprint is that this really involves three big bins or buckets of activities. Number one, extending precision medicine. We are all well aware of precision medicine in cancer care, but it's really a bigger look at precision medicine to understand how biology, behaviors, the psychosocial context somebody lives in, their resources, not only how that determines what anti-cancer therapy they should be on and their response to that, but also their risk of chronic and late effects and interventions that might be used to mitigate those. Second, we need to use those data to right-size care so that care is based on the complexity of their needs and their resources, shifting as much care as possible out of clinics to home via telemedicine. And again, this has happened in full force. You know, we put out this paper in 2019. Now with COVID, everybody has switched to telemedicine. And now the emphasis is on, okay, how do we continue what should be continued? Right? But we need to be making sure that we're freeing up provider time for the highest acuity patients. And then the third piece of this was using the same sort of understanding of need to right size the support that we're giving to caregivers. So let me take each of those in turn. So first, precision medicine. Again, you go to ASCO, you're hearing so much about precision medicine, but what you're hearing about is not necessarily, if you go back and read this New England Journal paper that Collins and Varmus put out in 2015, that was then launched from the then Obama White House. What they meant, the dream of precision medicine, was really integrating multi-source data, right? Molecular, genomic, cellular, clinical, behavioral data. You know, what health behaviors that person's engaging in and how often, their physiologic data, the environmental data that govern what they need to do during the day, their resources. Now, what are you doing with those multi-source data? Three things in Collins and Varmus's vision. Number one, enabling better assessment of disease risk, not just risk of cancer, but risk of those toxicities, risk of poor outcomes down the road. Number two, understanding the mechanisms that are producing that excess risk. Again, not just the mechanisms that work driving cancer, but also driving long-term and late effects, driving disability, driving excess costs, excess healthcare needs. And then number three, predicting the optimal therapy for, in this case, not just the therapy, the anti-cancer therapy, but the therapy that should be used to mitigate those toxicities over time. So why aren't we doing that? Well, a few years back, I had an aha moment, which is that we're supposed to have this bench to bedside, or really bench to bedside to population take on our research, but really where our research goes is this bookshelf, right? And I'm guilty of this as well, right? We all do this. You get a publication in JAMA or New England Journal or maybe JCO, and everyone says, "Yay, yep, done. I did. That's my check mark for promotion, for what I'm supposed to be doing as an academic. That's what I was supposed to do." But the problem with that is that we've gotten to this place where I call it the Great Divide, where it's almost like we've got these two land masses separated by this huge body of water. And the science, the weight of all of this incredible science we've been doing for decades is on one land mass. The patients we're trying to help with that science are on the other land mass. The health policy that governs how our healthcare is delivered is not even on this planet. It's on a red, swirling, gassy planet over, so the problem is we've got to build a bridge and seamlessly connect that. The result of not having that bridge right now, as the then Institute of Medicine put out in 2013, is that the US healthcare system and systems, right? We don't have one healthcare system, but systems today, our scientific insights are poorly managed. The insights from the evidence is poorly used because the science isn't being used. It's on that other landmass. And so the elements of care, right, are poorly captured, the outcomes of care, if you will. And at best, we're missing opportunities to speed the translation of evidence to practice. At worst, we're creating waste in our healthcare systems and actual harm, right? So we have to speed this translation of evidence to practice. I've put together this slide as sort of how I see the current state of cancer treatment, right? This is a little cartoonish, but bear with me. So somebody gets diagnosed with cancer and they're standing on this landmass with their clinician, and their clinician is standing there The rest of that person's life is on this other landmass, and you've got this huge chasm in the middle. The clinician's not holding the right tools to get them across. In this case, you got a lasso and a ladder, you're not going to get across that chasm, right? And the problems that are in that chasm are access to clinical trials, an inability to treat toxicity, and an inability to provide ongoing follow-up care that's personalized to the person's needs. So what is needed and what we're building at Northwell is a bridge that seamlessly connects that person from day one of their cancer treatment to the rest of their life by facilitating access to cutting-edge treatments that can preserve their function to the fullest extent possible, including access to clinical trials, that can build a robust data structure that can anticipate what toxicities are going to be, preventing what we can prevent, or mitigating them, catching those problems when they're small, to the extent that we can do that and prevent, as all of us clinicians in the room know, 6 other problems down the road that come from not preventing the things that we can prevent early. And then third, we're building follow-up care pathways that are actually personalized to what that patient needs. And we're building this bridge with data and analytics. So let me talk to you a little bit about what that bridge is. So what I am using for data for what I'm about to talk to you comes from several different then Institute of Medicine reports that they've been very interested in the learning healthcare system for a long time, at least the last decade and a half or so, interested in different pieces of it, first establishing the problem, then talking about what the solution looks like, talking about the digital infrastructure that would support a learning health system. There's a President's Cancer Panel from 2016 talking about connected health. This wonderful Network for Excellence in Health Innovation report called Healthcare Without Walls that Susan Dentzer led in 2019. It really talks about beyond cancer, how we re-envision what healthcare could be. And then 2 models specifically in cancer, one coming from the UK, our friends across the pond, if you will, in their national survivorship initiative. They're about 10 years ahead of us in pivoting their care along the lines of what I'm about to talk about. And then Australia started in about 2016, trying to pivot their care using the UK's approach. So from all of this, I'm gonna, people love to talk about learning healthcare systems, but nobody really knows what one looks like. And so we do know, though, what it does. And these reports tell us what it does. It first of all allows us to generate and apply the best available evidence for the collaborative decision-making that needs to happen between patients and providers. We know that a second goal of learning healthcare systems is that they drive the process of discovery as a natural part of what's happening in patient care. So research is really embedded into the system of care. And third, we know that the outcomes of a learning healthcare system are that we're speeding innovation, and we're ensuring quality, safety, and frankly, improving value in our healthcare. So in 2019 at ASCO, my colleagues and I from around the world actually came together to talk about the 6, learning from the UK and from Australia. What are the 6 systems that are needed to build this bridge in the United States? One of them is patient data capture, so that patient data are actually guiding care. The second one is using those data so that we develop clinical decision algorithms that can provide triage to the different care pathways using those patient data. The third one is the ability to remotely monitor patient status and give test results and remotely monitor outcomes between clinic visits. It's critical that we understand what's happening with that patient between the times that their clinician can see them. Number 4, we have to be building support to help our patients and our caregivers self-manage their wellness to the absolute extent possible. Number 5, the system should be coordinating care between oncology, primary care, specialists and subspecialists, and patients. It should not be that hub and spoke where the patient's at the center and each clinician and program they're in is around the side and none of them are talking to each other. They all only go to the patient. That's too much for the patient. And number 6, that as you design these programs, as the UK has pivoted their programs and as Australia's been pivoting those programs, we're learning that you've got to have all the stakeholders at the table from day one in order to make sure that the systems that you're proposing are actually the systems that are going to work for everybody. So I'm going to take each of these 6 things one by one. So the first is patient data need to guide care. Now, at ASCO, for the last several years, you've all been hearing a lot about patient-reported outcomes, and that's great. We need to be thinking about patient-reported outcomes, but we also need to be thinking about the fact that that is just the tip of the iceberg in terms of patient data streams, patient-generated data, right? We need information on that patient's social circumstances, how they live, with whom they live, their resources, their environment, what kind of job they have, their behavior, right? Their genetics, and then of course, at the bottom, the thing that we think about, which is their medical care. That's what's in all of our EHRs. And then we've got all of these different data coming from outside the medical systems that we need to be integrated with these health data. So colleagues from NCI and the Oncology Nursing Society and the American Cancer Society, I put out a report in JCO Clinical Cancer Informatics just last year, talking about what this actually looks like, how we need to mend the disconnects in cancer care through an IT system that actually works. So what you see here is that there's a data repository. So all of those different kinds of data I just talked about, from the EHR, from electronic patient-reported outcomes, from the Internet of Things, the medical Internet of Things, which is more and more the sensors we're putting on our patients, things that they have embedded, things that they are wearing, that data repository feeds into predictive analytics, right? So we're predicting which patients are going to have which need for anti-cancer therapy, for one thing, and also for which patients are going to have which kinds of toxicities. And understanding those predictive analytics feeds into our ability to develop prescriptive analytics, meaning what do we do about that? And that those analytics, those interventions need to be risk stratified so that we're really stratifying the resources that are going into helping that patient, making sure that we're giving them the help that they need. And that feeds into an intervention repository, so it's actually connecting to workflow. And that, as you can see around the side, there's continuous assessment of this learning health system. So when that article that I just referenced in 2018, the American Cancer Society and the Oncology Nursing Society came together to host this big, really there were 40 different tech companies at the table talking about what the pain points are in health IT, in an understanding how to build the system that I just showed you. And one of the things is this lovely Silicon Valley consultant said, you know, your problem in healthcare is that Nike knows how to use your data better to sell you the right pair of shoes than you people know how to use your health data to personalize healthcare. And she was absolutely right. So we have to understand how to integrate all of these data, but then to actually use them. And that's where a lot of us on this call right now who do prediction modeling, who do clinical decision support tool development, right? This is where a lot of us can really be helpful in doing a better job than Nike can to sell us shoes, right? So what we need to be doing is figuring out how to right-size care, shifting care delivery from what we call point of care inside clinics to point of need, right? If that patient's got a sleep problem, they don't want to talk to you about that sleep problem Thursday at 11 a.m. They want help for their sleep problem at 3 a.m. when they're having trouble sleeping. So we need to be delivering that through portals and apps at point of need wherever possible in order to actually improve outcomes. So this right sizing care, building these algorithms that guide triage to care pathways, right? It takes the prediction modeling and then the algorithm building. It should be about informing the choice of first line, but also subsequent anti-cancer therapy, of course, but also using that patient-generated data to understand the problems that people are having, those toxicities and their functional impact. It's not just asking somebody about their fatigue score. It's, you know, how is this fatigue limiting your ability to work or care for your children or your aged parents or whatever you do in life? and then connecting that patient to either low touch, medium touch or high touch help, if you want to think about it that way. So maybe at the low touch end, the person just needs some self-management with regard to their how to change their exercise behavior. Dr. Irwin, I'm looking at you up there, right? So maybe some patients can benefit from that, but maybe some need more help. Maybe they need a community or a worksite-based program, or maybe they need to link to telemedicine to have the help that they need with changing their exercise to improve their toxicities. And then at a high touch way, we need to be facilitating the right patients who are in need of our clinicians to clinical care, to that multidisciplinary team of clinicians as quickly as we can possibly do that. So to the extent that we are right-sizing care, again, thinking about the low touch, medium touch, high touch, to the extent that we can do that, we're improving patient access, delivering some of these things in the home where we can, delivering some of these things via telemedicine, but also decreasing clinician burden, freeing up clinician time for the highest acuity patients. So what we're learning from the England and Northern Ireland's pilots of what they call the stratified survivorship care is they've taken not just something like an exercise referral, but the entire system of post-oncology survivorship care, and they have stratified it so that the vast majority of patients, and in their pilots, it's 80% of breast cancer patients, 50% of colorectal patients, and 40% of prostate cancer patients get triaged to what is really self-care with supported self-management. And what that means is they're following with their PCP. In our language, in the US language, they're following with their PCP, but they've been taught, hey, here's what to look out for, and here is how to call your oncology team when you need it. Then a much smaller, going to that yellow group, a much smaller number of patients are treated in this shared care pathway, and a very small number of patients are treated in a really complex case management approach with a multidisciplinary team. And the choice of which of those three pathways they get to is really based on their needs, right, and their risk. So England started this about 10 years ago. They piloted it there in 12 of their clinics before rolling it out. They piloted in Northern Ireland, and they did a really nice job evaluating what happened when they rolled out this new kind of care. And what they showed is that this model met patients' needs actually more efficiently while improving their clinical efficiency. What do I mean by that? I mean, they actually improved the follow-up surveillance tests. So the timeliness of patients getting their surveillance tests, they improved that by 20%. They freed up their oncologist visits for new patients, decreasing their wait times for new patients who needed their oncologist by 34%. And they saved a lot of money. Now, they're the NHS. They can pivot a lot more easily than we can in the United States. But this was compelling enough that ASCO and the American Cancer Society came together in 2018 to start talking about, okay, let's learn from this model. Let's figure out what could be piloted here, what could be implemented, what might need to change, because US health systems are much more fragmented and variable in how we deliver that care. But how could we start to think about this stratified care model? And we put out a report in CA in 2019 that really presents a research agenda for getting us to those personalized stratified pathways that includes really the need to create and test some of those new care delivery models that will also then downstream need to create some clinical guidelines so that our clinicians know what that care looks like, so that they know what they're expected to provide, and that we develop some care delivery tools that can be used at point of care so that an individual clinician in care knows how to triage the patient appropriately to the right follow-up care pathway. Okay, third, remote monitoring of patient status. So it's absolutely critical in the system that works in the UK and in Australia. It is absolutely critical that what we do is increase our ability to remotely monitor how a patient is doing so that we're understanding their data are feeding to us, not just through some questionnaire they fill out in our waiting room before they see us, but constantly, so that we know what happens between the times that we see them, because that is the only hope for picking up an issue in a timely way. So what that entails is building a surveillance system that's monitoring our patients for, yes, the chronic and late effects of treatment, but also for recurrences and for subsequent cancers. So it has to be symptom monitoring so that we're detecting problems and triggering either self-management referrals or self-management content or triggering referrals to clinicians. It has to be detecting symptoms that might point to the need for imaging around surveillance and screening tests and advising them of normal results or abnormal results, triggering referrals back to the oncology team if that is what is needed in a very timely way. And the whole point of the return on investment here is that if we can, in a more timely way, detect these problems, we can not only optimize that patient's long-term health, but prevent these problems from becoming huge problems, right? We can catch that recurrence when it's small. We can catch that toxicity that before it gets to heart failure, right? Decreasing downstream healthcare utilization and frankly, preventing suffering. So at Northwell, we have developed this schematic that talks about how patients really need to be followed in what we're calling the prospective surveillance model. And I know this is a busy slide, so bear with me. So we start up here at diagnosis, right? The patient is diagnosed with cancer. And we're grabbing the data from the EHR, right? So their histology, their insurance status, lots of other things coming from the EHR, comorbidities probably. We're marrying that with patient-reported outcomes data or other patient-generated data from things that they're wearing or sensors that we put on them. We're collecting things like symptoms, like their ability to function, their needs for immediate needs for care, and their preferences for how they want to be treated. And then if you follow this down the side, those data and that data integration is funneling into clinical decision support algorithms that are identifying the need. Again, this is diagnosis, so identifying the need for a clinical trial or for a frontline, first-line cancer treatment, and for any immediate referrals that they might need. Maybe they already need that physical therapist, right? Or they already need social work. And then that is channeling into clinical workflow down the side. So that it's not just about collecting data, it's about the three-pronged process of collecting data, informing clinical decision support algorithms that then actually link to clinical workflow. That's the way to get ROI out of a prospective surveillance model. And by referrals to subspecialists, I'm thinking of this whole big multidisciplinary team that patients might need from diagnosis forward, right? We talk a lot about oncology's role, about primary care's role, but where is everybody else, right? So we need cancer rehabilitation and palliative care and psychosocial care, cardio-oncology and onconephrology and genetic counseling. And depending on what this patient's being treated for, you know, maybe people like dentists or the endocrinologist, the neurologist, audiologist, lots of other people, exercise and nutrition, right? And then of course, down here, front and center, the ability to help that patient self-manage and engage, empower them to engage in their care and support that caregiver to engage in that care as much as we can. So this team is much bigger than people think. So then the whole point of at diagnosis, we're getting these data that are feeding into clinical decision support that are linking to clinical workflow. This system continues throughout primary cancer treatment, and it gets repeated multiple times. That's why we call it a prospective surveillance model. It continues to the end of primary treatment for those who get there, where it triggers, here's this inverted triangle like in the UK and Australia again. So this same system identifies the need of data that that feed into clinical support algorithms, then feed into the choice of risk and need stratified care pathways, where maybe low risk, low need are following predominantly in primary care with self-management like in the UK. The moderate risk, moderate needs, and high risk, high need are following in our special survivorship clinics with varied intensity of follow-up. And this system continues throughout the identification of a new problem, whether that's a new cancer or a new toxicity. So that's the prospective surveillance model. Now I want to talk about support for self-management, and this is patient self-management and caregiver support for self-management. So recall from the UK model that, again, they showed was very effective in their evaluation of pivoting across 10 years. This green, the vast majority of patients are treated in this big self-care with support and open access pathway. What that means is that we are spending more of our time than we are right now helping our patients understand what they're at risk for going forward, what they should be looking out for, and giving them the tools to know what to do about that. So it's that piece of self-management married with the fact that we're telling them, and we have this remote surveillance on you, right? So we're checking in with you at times while you're not with us. That two-part program is going to help patients feel like we have their back, right? We're monitoring what we need to monitor for them. And so they'll feel comfortable in that self-management arm, following only with their PCP, even if their PCP doesn't know hardly anything about their cancer. So my colleague Doris Howell and colleagues from across the globally, actually, and I came together to put this paper out in JNCI last year, talking about what it's going to take. You know, self-management, you say asthma management, and everybody knows that has to do with self-management, right? We have to help people manage their asthma. Any of you who have kids with asthma, you know that very well, right? Diabetes care. We know that it's a huge focus on self-management and learning how to deal with your finger sticks and your glucose monitoring, right? In cancer, we have not been talking enough about this. So we have to talk more about how to support our patients in understanding what they can do for themselves. And this is that behavior change too. This is understanding that what they eat, how they exercise, how they move, what they do every day is really some of the most powerful medicine that they can do for themselves over time, for their overall wellness. Fifth, care coordination, right? So we learned from the UK and from Australia is absolutely critical for the system to do more of the coordination so that all of the coordination of these different parts of care it's not just on the patient, right? So we talked a lot in the literature. There are big debates about coordinating care between oncology and primary care. Yes, and where's the patient in that, right? And how do we help alleviate the stress on that patient, on that caregiver? How are we bringing in the specialists and subspecialists that person is seeing, right? So we have to think about coordinating care amongst all of those different stakeholders at the table, because when patients are active participants in their care decisions, first of all, you get better adherence to care. You also get, think of your Press Ganey scores, you get better satisfaction with your care and you get better outcomes. So it's a win-win-win. So this is something, this better coordinating care needs to happen during treatment, and it needs to happen post-oncology treatment for those who get there, right? Where we're communicating with primary care to help them understand the care that they should provide. We're communicating with patients about their self-management, right? And I know I get accused of being a kumbaya type person when I say that technology can really help bring people to the table, but if we can use technology for good instead of evil, meaning obsessive box checking, then we will actually get there, and it can facilitate everybody being on the same page. So finally, the sixth piece of the learning healthcare system, engaging every stakeholder in the design of that learning healthcare system from day one. So anybody who's got an iPhone on them right now, the reason why the iPhone got developed and actually became this thing that all of us wanted on day one is because the way that it was designed, they had all of the supply chain and end users in the room from moment one. So they knew that they were making a product that people wanted, that was feasible to manufacture, with every piece coming from where it was going to come from, that was able to be marketed, that was able to be produced and shipped all over the world to meet the demand. And that was something that people would go, oh, I need that right now. How did I ever live without it? We have to think like the iPhone developers, right? So engaging all of our stakeholders, securing their buy-in, and using these good change management and continuous improvement processes that you probably have these teams at your hospitals right now. So use them to help to facilitate your care transformation. So, and it goes two ways, right? We need buy-in from the top down. This is your C-suite, right? We need your clinical leaders, your management to endorse this new care delivery change. But what we know is that if we don't have this push from the bottom up as well, it won't work. And bottom up push needs to come with patients, families, our frontline clinicians saying, yes, that thing is what I need, right? That is, I'm going to be pushing from the top down and from the bottom up, then we get there. So in a learning healthcare system, research and practice are completely integrated, and it feeds continuous learning. Okay, so I put together this image it's really woven. Medical care and research are woven together like a double helix. Why? Because a double helix is so strong. And this is the promise of a learning healthcare system. So we're getting information from medical surveillance, the imaging, the labs, the tests that you're all running to detect recurrence and subsequent cancers and those late effects, but also the symptom monitoring, the function monitoring, right? The understanding the long-term and late effects of our cancer therapies and the timely referrals that we're making. At the same time, we're creating a system where those data, the analytics, can truly drive personalized care. So a learning healthcare system can predict patient risk, patient need, and frankly, an intervention response. So which patients are going to respond best to both their anti-cancer therapy and to something like what type of exercise do they need, or what type of physical therapy referral do they need, or who needs a cardio-oncologist. And at the same time, you're getting consent, universal consent, so that you're you're analyzing data and saving blood and unused tissue samples so that you're creating a true research registry. Because one thing you all know, being in survivorship, is that we're constantly behind as oncology comes out with new drugs, new ways of treating patients. We don't know what the long-term impact of those are on survivorship. So this has to feed a continuous learning system so that we can understand in real time, refine our prediction modeling, right? To understand the ongoing paradigm of long-term toxicity, risk, needs, and prediction. So again, that paper last year in JCO Clinical Cancer Informatics, we talked about that really, how do we get there? How do we make this work? And we talked about the fact that there are 4 national strategies that we need to catalyze that will facilitate the development, adoption, and use of these learning oncology systems. So one is shaping public discourse about these so that we're understanding and shaping public opinion, so that we're facilitating the adoption and use of these, so that people want this as much as they want the iPhone, right? Secondly, that we're demonstrating the value proposition of a learning oncology system. So to the extent that we're pilot testing this and testing the effects on patient level outcomes, yes, but also, are we decanting oncology clinics? Are we making providers happier and more, and are we making their days easier, and payer level outcomes? And are we facilitating new care delivery models through creating guidelines and clinical decision support? And then finally, that we have to incentivize and regulate these new care elements. And that's reimbursement, quality metrics, accreditation standards. Some of this has really changed with COVID, right? So you are all very aware of how CMS came out with, and private insurance followed, came out with new metrics for reimbursement for telemedicine, for remote monitoring codes, so you can bill for that, right? A lot of the incentives and regulation has changed with COVID, and now we need some of those things. We don't want to walk those back, right? They need to stay, or we'll never get to the learning oncology system of the future. But for all of you who are involved in science out there, we talked in this paper that this developing a learning and developing and establishing the value proposition of a learning oncology system or a learning healthcare system for oncology really requires that we change the way we do science, right? You can't just do your standard RCTs, or you're going to still have that 17 years from evidence to practice, right? We have to change to do models that are more flexible, adaptive designs, that are thinking about scalability and pragmatic trials, non-randomized designs, and really thinking about rapid iterative prototyping so that you're fielding a new care pathway and you're understanding, did this work, or a new intervention? Did this work? And in real time, I'm going to put out version 2.0 and see how that works. So we really need to think like engineers think in terms of coming out version 1.0, 2.0, 3.0, rather than, okay, here's my 5-year R01, and then it's going to take me my 2 years, I'm going to get my second R01, right? We can't keep going in that same model, or we'll never get there. So if you're all thinking, well, that was interesting, but how on earth would I begin to do some of this at my institution? I think, you know, the reason why I left the NCI and the American Cancer Society is really, in the words of Elvis Presley, because we need a little less conversation and a little more action, please. Right? I wanted to jump to a system that actually called me and said, hey, we want to do some of this. We want to experiment with care. We want to innovate our care because we have to, because we're feeling that tsunami wave behind us. And so how do you start? You start by building what engineering calls the MVP, the minimally viable product. So it's version 1.0. I like to think in terms of, oh, version 20.0 is going to look like this, but I've had to learn to back it way up to what is the MVP, right? How can we create the smallest possible thing that's really a pilot test, and then we will build on that success. So how do you decide what your MVP should be? Well, think about where your bright spots are. You know, do you have a breast clinic where your clinicians are really focused on this? Do you have IT that works in your head and neck clinic but nowhere else? You know, think about where your bright spots are that are working well, and figure out how you can connect those to start thinking about building out a learning healthcare system. And then as you test that, think like a good scientist thinks about evaluating the return on investment from that, because otherwise you won't be able to go to bat for scale. So are you getting the higher quality care? Are you getting healthier patients? Are you getting happier clinicians? Are you getting greater efficiency of care delivery? And are you getting lower cost? For my leadership, I created this 4-matrixed ROI document, right? So they said, well, what are we going to get out of this? And I said, well, I think if we build a learning healthcare system for oncology, it really solves this complex problem that we think of as meeting the quadruple aim, right? So over here in the fuchsia, we're driving patient outcomes by facilitating more timely access to cancer clinical trials, and by monitoring patients so that we're facilitating meeting their needs from diagnosis forward. And because we're building these consistent follow-up pathways that are personalized to their needs, we're driving our patient experience of care, better patient experience of care, by coordinating and integrating their oncology, their primary care, their subspecialist care, providing a seamless transition from oncology to follow-up care. So they see that as one continuous pathway of care, not what we know from the research. They feel they get through with oncology care and they feel dumped, right? And they feel out there on an ice floe and they're scared. So that seamless transition, and providing that high touch, but virtually wherever possible, so that we're driving better patient access to care. Very important to me that we're creating happier clinicians by enabling the provision of best-in-class care, which is every clinician I know went to school to become, to do, that we're prioritizing their time for the highest acuity patients that need them most, and decreasing their administrative burden, which we know from the research is the massive predictor of burnout. And finally, we're driving care efficiency by increasing our downstream subspecialist referrals, getting people to that physical therapist, that cardio-oncologist, that onconephrologist at the point where those clinicians can actually help. And we're increasing our new patients that we're able to see in oncology by shifting patients out, follow-up patients out of oncology, so that we can better meet the need for that tsunami wave of new patients. Also retaining patients, improving our accreditation standards, yada, yada. So why do this now? Well, I think now is absolutely the right time. And it's because of this confluence of external factors. So we all have seen the rise in cancer, as really people are even thinking about it. Reporters that I talk to now say, you know, cancer is really a chronic disease for a lot of people, isn't it? Yeah, it is. But yet it's one of many comorbidities that a lot of our, especially older adults, are managing. So we have to think about treating it as a chronic disease, and that's a very different model than cancer's used to. We saw in this last election, and this is not likely to change, that healthcare was really the top priority. So healthcare and making healthcare more efficient and work better for patients and for healthcare delivery systems is top of everybody's minds. And now we've got these COVID-related policy initiatives that have addressed barriers, right, that to creating this in the past, like telemedicine reimbursement. We're seeing hospital at home codes, remote monitoring codes. We've got basically increased support across a lot of different kinds of stakeholders. We have more national reports outlining solutions than you would even believe. We've got CMS pushing for value-based care. They've been in survivorship, they've been pushing oncology models. They're very interested in survivorship models, value-based models. I think we're gonna see pushes toward self-management, toward more wellness, because that's really value, right? And we're seeing them experiment with radiation oncology models, with primary care models. I think we're gonna, I would bet we're gonna see one in survivorship somehow. We also have a lot of focus on building better data systems at NIH, at FDA, and we have, because this is America, an amazing number of innovative tech companies that are just begging to work with all of us as clinicians and researchers and administrators. They want to play a role in healthcare, and if we can figure out how to involve them in business models that work for them and us, that's a win-win. So I want to finish where we started, which is that we owe it to our patients, right, to help achieve this balance. Patients need us to balance their tumor response with their function and their quality of life. We are all in oncology in the business of saving lives, and that is an incredible business to be in. At the same time, though, we have to make sure that we're attending to patients' functioning in life and their quality of life so that those lives that we are saving are worth living. Thank you. So what part of this can you take on? Where are there opportunities for collaboration? Please, ping me. I would love to talk to you more about that.
Thank you so much, Catherine. What an inspiring talk, but also to be honest, feel a little bit I wish we could just flip a switch and the system has changed completely to have everything that you just recommended. And I have a quick question that I'm going to turn it over to the chat box questions. But what I find challenging as a scientist in translating science to practice is, it's even harder than translating basic science to clinical and population science, is that implementing the science in practice involves different stakeholders than the scientists doing that implementation science research. And so who the stakeholders are and getting them all excited and wanting to create this change, I find very challenging. So, any additional sort of insight in how to get, because towards the end of your talk, you were mentioning the stakeholders, but how to really get them all willing to put the time and attention that is needed to this.
Yeah, so I think it's critical. I mean, obviously, I'm less than a year into my new job at Northwell, but one of the first things I did was to try to figure out who are the stakeholders, right? As any of you who have taken on a new job, right, the first thing you have to figure out is, how do I get stuff done here? Who do I need to talk to? What's the currency here? What drives innovation here? And so I look to each of you to figure out, if you want to start to, build a learning healthcare system to better facilitate that evidence translation, who are the stakeholders that need to be at the table? So just a Northwell example, one of the ways that I quickly got introduced to this, our patient experience team. We have a patient experience team and a digital patient experience team. And at Northwell, it is corporate culture that patient experience is a massive driver of innovation and care. And so I figured out very quickly as a scientist, okay, we need to leverage that in everything we do. Every one of our 23 hospitals has its own patient experience committee, right? Its own group that works with us, that helps advise us on the things that we're doing. So that's the onus is now on me to be working with all of them to bring them to the table as we're taking this big vision for across all of our system in Northwell and implementing it at the local level to make sure we have local buy-in from those patient engagement panels, from those groups. And the same thing with clinician leadership. I spend a huge amount of, I almost feel like Congress, right? I'm spending a huge amount of time going around behind the scenes, trying to set the stage for what we're trying to do, because getting those stakeholders together is absolutely critical. So start by thinking about who are they and who do you have and who is strong.
Well, and I think within SWOG, what is really exceptional is our patient advocates. And for our survivorship committee, we have Lee Jones, but there's 20 plus different patient advocates who I think have a strong and important voice. And so I think we really try to include them from the infancy of any sort of concept forward. So in a moment, I'd like to hear Lee's thoughts on that. But I'm going to turn you over to the chat box where Dr. Young, Rachel Young, had a comment, and I think this is tied to what we're just talking about, that she, as an oncologist, finds that the reality of low touch, medium touch, and high touch varies as much by that patient's self-advocacy as much as disease risk, and that there are DEI, diversity, equity, and inclusion issues around this. And so how do could you speak to this with the patient's self-advocacy? Dr. Young, I hope I spoke to that correctly.
So I love that question. Thank you for that question. So a couple of things. So one, I asked Professor Jane Mayer at the NHS in the UK, where's your risk stratification algorithm? Can you just give it to me so we can start with that? And she said, really? To an individual clinician in practice, the choice of those 3 follow-up care pathways depends entirely on that patient's, yes, it's a risk of morbidity and mortality going forward, but it's that patient's ability to self-manage. Because depending on the resources that you're involved, that you have at your disposal, depending on what else is going on in your life, the job demands you have, the child demands that you have, or whatever it is, your financial resources, your culture, you brought in the diversity and inclusion, absolutely. I mean, we just acquired last year, Queens Medical Associates. People speak over 100 languages in Queens. And so as we're rolling this out in Queens, I have to be really, and the team, we have to be very attentive to cultural, both cultural needs, cultural biases, cultural thoughts about, for example, I had one of my staff members who's African-American said, when you say risk stratified to me, I say my population is going to get hosed, right? Because that's what it means. And I thought, wow, I never would have thought of that, right? So I'm so grateful that she said that to me, and I could think about the need to, it's marketing, but it's also being inclusive in those voices, right? In helping people to understand what this new care looks like, why we're doing it. Same thing with patient-reported outcomes. I realize I'm going on and on, but there are so many different pieces of this, and you've got to have those diverse voices at the table informing how you do that. Mm-hmm. Great question. Thank you.
Thank you. And Catherine Guthrie, who's the statistician in our survivorship committee, has a question.
Yeah, this is Catherine. So great talk, really fascinating. But as a statistician, of course, when I see your slides, I'm thinking that is a lot of data. That's a ton of data. That's a ton of IT work. Like, I think people sometimes, I'm not criticizing you at all, but sometimes people think like, well, just throw it all on the computer and it will spit out all this stuff. You know what I mean? And that's not a static process, right? Like it's an ongoing, evolving thing where it's very complex, right? So my question is, I'm thinking any system like this requires a huge investment in data management, in clinical research, people who like call patients and like make sure they've got the right data, and IT people and programming. I mean, all this stuff. I just wonder, how does that work? How do you think we're willing to do it? Because it's not clinicians, right? It's people like me. So.
Yeah, and I think people like you, I'm going to say that, right? So that's a whole nother talk I could have given, which is how we're staffing up and trying to build out this massive data science infrastructure that supports a learning healthcare system. And I'm not going to be honest, it's not that our CEO, I would love to say, oh, Michael Dowling is amazing. He is amazing. But he didn't just say, yep, green light, spend whatever you want, right? That's not what he said. So we absolutely are busy working constantly justifying the need for biostatisticians, every kind of data scientist you can imagine, right? We call it our quantitative intelligence initiative, because it's really a lot of different kinds of modelers and data wranglers and data managers and every kind of data scientist imaginable. And so we have to do, it's on us, right, to justify why that is as essential for building this as any of the other components that I've just talked about today. I believe that's true, but we have to show that. We have to forecast that. We have to build, frankly, a business model for that. So that's what we're working on right now.
Great. And I think
Great
a final question from Don Hirschman. Don, I don't know if you want to state it yourself, or I can read it as well.
I mean, I guess my question is, from the cooperative group.
It's a little bit of a poor connection, Don. I think your question is about the self-management strategies, and is that a good topic to help guide patients?
Sorry, Dawn, that we can't hear you. I think, so just to clarify, so self-management, building out self-management content is absolutely critical to building that stepped care approach to, so for example, just take sleep, right? I gave that example of the person who's really struggling with sleep needs some self-management of, hey, behavioral sleep hygiene, and have you tried this? Have you tried that? They need that through their portal or their app at 3 a.m., not when they come see that provider, Thursday at 11. So building out, I think, but identifying how to build out that self-management content, what it needs to look like, how you need to engage people in that. Again, to the question earlier about diversity and inclusion, how you present that, not as, oh, we're putting you out on an ice flow, go self-manage, right? Which is, when I talk about self-management, a lot of what Americans hear. In the UK, they were a lot quicker to embrace that, because self-managing, as they tell me, it's a British value, right? It is a literal base British value. And so Americans value getting my money's worth out of my healthcare, which is a different value. So we have to think about how, as we create self-management content and help our patients self-manage and take over as much of their wellness as they can, we have to figure out how to do that in a culturally appropriate way. And I think there's a lot of research questions there. Absolutely. Hopefully that answered your question.
Thank you so much, Dr. Alfano. This was inspiring, and I look forward to talking to our SWOG members about how we can use the SWOG platform to move forward many of the questions you posed. Thank you so much.
Great.
Thanks,
Thank you for having me.
Thank you.
And you're welcome to stay on if you want to hear some of the research going on, but it's also fine if you want to log off. I'm sure you're busy and have other meetings.
Sadly, I'm going to go justify our biostatisticians. So that's my next meeting. So yeah, I know. I see it. Woo. All right. Bye, guys. I hope
Thank
to be
you
with
so
again
much.
soon.
Thank you. And then very appropriately, next on the agenda, we're going to have our patient advocate, Lee Jones, share with us what he's been up to, and maybe he can also reflect a little bit on his thoughts from that presentation. Lee, you're up.
Yes, indeed. Well, thank you, Drs. Moore and Irwin, for all the leadership you provide for the Survivorship Committee, and all that you help do for us patients and survivors in the real world. That was an amazing, not just a presentation, but I think the whole concept is amazing. And as she said, survivors should say, yes, that thing is what I need. And that's indeed what we need. And it's not what we get at all. Some people like me are lucky to have had not a lot of late effects and whatnot, so we haven't really needed a lot of care and attention. But for a lot of people, that's not the case. So yes, I wanted to update the group on a couple of things that have been happening recently, and actually it's very recently. Last week, in fact, the University of Minnesota had a really great survivorship conference, of course virtual, and it reminded me of the old ASCO survivorship symposium, except two things. It was virtual, and it really had patient involvement. Patients were on some of the panels, patients were some of the speakers, and that was never the case back in the ASCO days. But I wanted to reflect some of the things that came out of that meeting, and some of it's in no particular order. They did refer to a paper, and I got a copy of it that I sent the two of you, and I can make it available. It's sort of a pre-publication paper. It's going to be in JNCI, but it's called Evidence Gaps in Cancer Survivorship Care, that came out of a meeting the NCI had back in 2019. And they have a lot of narrative, but they also have some recommendations and priorities at the end that I wanted to reflect some of those priorities. And fortunately, I think they really align well with the priorities of our group. Let me see if I can get this called up. So at the end of the paper, they talk about priorities that came out of this meeting, survivorship workshop research priorities. I won't go into a lot of detail, but I can make the paper available. Surveillance for recurrence and new cancers, number one. Management of long-term and late physical effects. Management of long-term and late psychosocial effects. Health promotion, care coordination, financial hardship, and then finally, cross-cutting needs. And I'll go into a little more detail here. Understand and address disparities by including understudied, underserved, and vulnerable populations in studies. Conduct longitudinal as well as longer-term follow-up studies, more than 5 years. Incorporate implementation science expertise in interventions to translate findings from observational studies and efficacy trials into practice. They made this a real issue, is that we really don't need more studies. We need to have studies be incorporated into clinical care so they actually have some effect for patients. And also leverage existing studies, both observational and interventional, for cancer survivorship research. So that leads to a number of thoughts that I got basically from the NCI presentations. I will have, they just sent a copy of the recording of the conference today, but I tried to link into it, but the links didn't work, so I've let them know about that. Hopefully it'll get fixed, make that available. But in April is going to be, I think, some sort of a training course based on that conference that will actually have some professional development credits that people can get from taking part of that. So NCI is interested in the overlap or lack of overlap between survivorship and primary care. That was a major thing that came out, is that so many people fall between the cracks and their primary care is not really engaged in cancer survivorship. They refer to something called the Cancer Trend Progress Report that they said could provide a lot of nice front-end material information for grant applications, which they mentioned. They also mentioned that there's a grant applications, sample grant applications are available that you can use as a model for successful applications. They talked about a modular R01 that has simpler budget requirements and therefore easier to apply for and to get. They mentioned opening up existing trials to add survivorship outcomes as a follow-up, which made me think about the fact that we should be talking to the SWOG drug-based committees to try to add survivorship components on the end of some of their trials. So we can see what really happens as we follow these people, you know, past the clinical trial stage into real life. They talked about a new U01 pipeline called Metabolic Dysregulation and Cancer Risk, looking at obesity-related cancer risk. They were encouraging early-stage investigators, less than 10 years after their terminal degree, can get funding. They talked about a 16% pay line, which I assume means that they will accept more applications, plus 2 extra years of funding if their application is scored above the average score of all the applications. And they also said NCI probably won't fund studies that are not sustainable, and implementation is critical. So I thought that was all really worthwhile information. And unfortunately, the next one of these, apparently Stanford is considering having one of these, but it won't be until September of 2023. So it's a long time to wait. And then just yesterday, I was on a mini conference. UCSF put on something called Improving Cancer Outcomes with Diet and Exercise. And they focused on diet and exercise for prostate and colorectal cancer, but they have a lot of resources they talked about. They're putting some more online resources available. for anybody to access and look into. Also, in terms of studies for metastatic patients, the NCI is having a conference May 10th through 11th. I'm actually going to be on a panel in this. Survivorship needs for individuals living with advanced and metastatic cancers. So that's something I've been encouraging us. Why do we keep metastatic patients out of our studies? No, we should be including them in our studies and maybe even having specific studies that focus on metastatic survivors. So those are the meetings and conferences. The one other thing I wanted to mention is that I've been working with Dr. Baracos recently, who's a committee member, to put together a expression of interest for a Cancer Grand Challenge grant for cancer cachexia, which looking at, so I'm actually on a Cancer Grand Challenge project already looking at the relationship between the microbiome and colorectal cancer. But having looked at Dr. Baracos's preliminary materials, I think we have a real good chance of winning that. And that would be a long-term international study that would include patient advocates from around the world, as well as researchers from around the world. So those are the primary things that I wanted to bring to everyone's attention. And, you know, as I always say, I'm ready, willing to review any proposals people have, get involved, advance the stuff forward. You know, with 18 million survivors, need more and more from us. And we need to find ways to provide more and better services to them. And I think that the last presentation we heard is incredible, difficult, but incredible. I mean, isn't immunotherapy difficult? 20 years ago, if you thought about it, you say it's impossible, never can be done. And it can be done if we set our mind to it. So thank you very much for the opportunity.
Thank you, Lee, and thank you for all that you do. And yes, everybody who's on the agenda today to share your ideas, be sure to include Lee very early on in the development. We've got a lot still more to go today, so I want to move next to Justin Floyd. Are you on? And you can update us on S1501, and I think you have a little something fun to share as well.
Yeah, thanks, Holly. Can you hear me?
Yes.
Yeah, I think my co-conspirator, Jonathan, is on. I've seen his mug in the top corner there a time or two. So we do have something fun to share. So I'll make my comments brief and use our time for Jonathan. So this is an update on S1501. We can move to the next slide if you want. So as most of you know who have been on this committee, this is a fairly straightforward trial. This is the schema. We're essentially looking for women or men who are at high risk of developing cardiac dysfunction from HER2 targeted therapy for metastatic breast cancer. And we're evaluating the role of a blood pressure medicine, carvedilol, to reduce the risk of cardiac dysfunction. And then we, in addition to looking at the ability to reduce cardiac dysfunction, we have a lot of secondary translational endpoints built in the study. Pretty neat trial. It's going to give us a lot of clinical information on patients and a good amount of biospecimen to do translational aims with, in addition to the primary endpoints. So next slide. So as you can see here, we've kind of leveled off the 0 as the first part of April. So we've had accrual since, but we probably leveled off around 5 patients a month, which is slower than we'd like. Looking at the graph up on the top left, you can see some sites have had very robust accrual, you know, like City of Hope up to 39 patients. It's fantastic. So that shows that you can accrue robustly to this study. And so we've met with several different entities trying to help figure out, you know, how we can get people to have more of the City of Hope or Case Western, Heartland experience. And as a result, we're putting together an amendment expanding some eligibility. Thanks to Lee and some of the other folks, we've engaged the other NCTN groups and have a meeting with Alliance next Friday. So hopefully that will help get some enrollment and participation from Alliance. We are moving forward on our translational piece. We're actually getting ready to ship the biospecimens and start the baseline work on that. So if you don't have open or you don't know if you're open, look to see if you have it open and please open it. There's our email with SWOG S1501 question. If you have questions, email me. And Jonathan is on, and I'll let him introduce our latest attempt to improve accrual. So thanks, Jonathan, and it's all yours.
Oh, thank you, Justin. And I also have my producing partner here, Eric Stone. Just a side note, thank you, Justin, for teaching me and Monica. I'm a Hollywood writer and producer. Thank you for teaching me about cardiotoxicity. I think this relationship is an example of how the medical community and the film community could work together to take very important messaging and bring it to the public. You might recall back in Chicago when we were able to meet in person, Eric and I showed this committee a Ripple-matic, which is essentially a storyboard for episode 3 of the Cancer Brief project. Just a reminder for those who might have forgotten, Cancer Brief is a project, a Hope Foundation pilot program that is a digital engagement project that Dr. Don Dizon has been helping us to oversee and shepherd in. It's a 3-episode project looking to see if we could use infotainment to educate about cancer clinical trials on a whole. All 3 episodes are different in style and take, and also with their goals and purpose. Episode 1 is a faux news show in the tone of Vice News, educating about cancer clinical trials on a whole, the NCTN and the Hope Foundation. Episode 2 is a PSA straight to camera, trying to educate about cancer disparities. Episode 3, which we're about to show you, is seeing if we could actually educate about one cancer clinical trial. In working with recruitment and retention, they recommended that we promote S1501, and that's when we got together with Monica and Justin to learn about this trial. And we posed a question of, hey, have you guys ever made a commercial? And they said, no. That's interesting. So we kind of brought our brains together and came up with an idea. And yeah, Eric and myself are here to answer any questions you may have. We'll also kind of get into the marketing plan a little bit and get into how we made this during COVID, which was definitely a challenge for us. But that being said, I believe IMS WebX1 is going to share the screen, and lights, camera, action. Let's go.
You can relax, sweetie. I'll have dinner ready in no time.
Our biggest sales event of the year, and the one you don't want to miss.
And I actually asked them if they would be willing to videotape it for me, to use it as an educational tool.
This is Megan, and she isn't letting her metastatic HER2-positive breast cancer stop her from living. Megan is a fighter. But she isn't just fighting for herself. She's fighting for her family. She's fighting for more birthdays, more holidays, more time for firsts, and more memories that she'll never forget. Because she's regularly receiving Taxotere, Herceptin, and Perjeta, she'll hopefully have more time for all of it. Side effects of these medications can include headache, nausea, hair loss, muscle or joint pain.
Hey, Beth, wake up. Those are just the immediate side effects. You need to know about the long-term ones too. I get it. You're only focused on beating cancer right now. But these medications can lead to serious side effects down the road. But don't take it from me. I'm just an actress. Here's a real oncologist who specializes in treating breast cancer.
Beth, she's right. I'm Dr. Hopte, a medical oncologist. HER2-positive accounts for about 25% of all breast cancers. But most importantly, we have effective ways to treat it where we target HER2. This makes me very optimistic that we're going to be able to control your disease. We do this with drugs that target the HER2 protein, Herceptin and Perjeta, and a type of chemotherapy called Taxotere. We're also aware that these targeting medications can damage your heart, causing the muscle to become weak and potentially fail. If it happens, your doctor may not be able to continue you on these medications. I'll let Dr. Cody tell you more about that.
Hi, Beth. I'm cardiologist Dr. Cody. The chemo you're on does a great job killing breast cancer cells, but unfortunately, it may kill healthy heart cells. Also, Herceptin, one of the targeting agents you're on, can prevent the heart from healing itself, and it may eventually lead to it giving out. Thankfully, if it's detected early, there are medications that can help.
See, Beth, I might be a breast cancer expert, but I'm not an expert of the heart.
And I'm a heart expert, but not a cancer expert.
And I'm still an actress.
That's why we're working together. We're seeking a way for HER2-positive patients to continue on their medications, while also avoiding heart problems.
Okay, so how do you do that?
The medical community does this through clinical trials. These are closely monitored studies done in the safest and most ethical way possible, so we can improve treatment with new medicines and methods of care.
Some pharmaceutical company trial?
Well, that's one type of trial, but there's many different types. The cancer trials we conduct are taxpayer-funded, designed and run by doctors, and patients volunteer for them. Our trials are supported by the National Cancer Institute, or NCI for short, which is part of the National Institutes of Health.
In these trials, doctors, nurses, scientists, statisticians, and other experts collaborate to answer important questions so we can improve the outcomes of all our patients.
Are you running a trial for patients like me?
Yes, it's SWOG's S1501, and it's being offered in nearly 100 hospitals and clinics across the country.
In S1501, some HER2-positive breast cancer patients will be given a blood pressure medication, carvedilol, while receiving treatment. We hope this will allow patients like you to continue their cancer medications longer and thus increasing your chances for survival.
Plus, it gives us a better idea of how common heart damage is in breast cancer patients who are at risk for developing heart issues and who are taking medications to target the HER2 protein.
By enrolling in this trial, I'd be helping other HER2-positive patients?
It would help us answer questions that we don't currently have the answers for. But if the trial is positive, it might mean carvedilol can be helpful for patients with other types of breast cancers.
For more information, visit cancer.gov and ask your doctor if S1501 is an appropriate trial for you.
I'm enrolling in S1501 not just for myself, but for all the other women in the future who will be diagnosed with HER2-positive breast cancer.
Did my doctor ever say anything about a clinical trial?
I don't think so.
Well, there you have it. I don't think the video was optimized appropriately, but you guys get the whole kind of idea of what's behind it. And yeah, we're here to answer any questions you may have, and we hope you enjoyed it.
Thank you so much for sharing that. I think we're gonna have to cut any question and answer short just because we have a lot to discuss in the remainder of this meeting, but we really appreciate you sharing that and for the Digital Engagement Committee to adopt this trial and moving forward with advertising for it. Thank you.
Sure.
I think people, too, if you have any questions or comments, please put them into the chat box. I really appreciated the commercial and how it's educational. Interested in thinking about now that the COVID vaccine was developed, if the nation as a whole is better understanding of the importance of clinical trials, but not sure.
It's definitely an appropriate time. I'll put my email in the chat. If anyone has any questions, you can just email me.
Perfect. Thank you.
Thanks, Jonathan.
Do we pull up the slide deck?
Yep. We'll need the next slide.
Okay, so now we're going to go on to some individual concepts that are in different phases. And next up is Dr. Leah Ferrucci, who's an assistant professor at the Yale School of Public Health. Leah, if you want to present your concept.
Sure. Are you able to hear me okay?
Yes.
Okay, great. So this is my idea that I had working with my mentor, Melinda Irwin. So we have been interested in thinking about obesity changes after diagnosis. We're hoping to potentially utilize some of the data that's already been collected in some of the existing SWOG trials. Next slide, please. So we know that there's robust evidence for the role of obesity in cancer incidence, and then there's a growing interest in trying to understand obesity in relation to mortality in cancer survivors. At the moment, the majority of that research has been limited to assessment of BMI only at diagnosis or very close to diagnosis. And the literature that we do have on weight change after diagnosis is primarily among women with breast cancer. It's starting to grow for other cancer types, but again, most of the data that we have is for breast cancer. Overall, we also know that the prevalence of obesity is increasing more in cancer survivors than our general population. So this is really bringing this to the forefront as an emerging problem. And there's also the potential within some of this new work that we're hoping that we could study some understudied mechanisms that may help us understand relationships between obesity and cancer outcomes. I've listed a couple of the ones that we were hoping to focus on in a second project that I'll touch on, but these include the microbiome, the metabolome, as well as epigenetic age. Next slide, please. So the first project that I had already alluded to would be a secondary data analysis, and this would utilize existing SWOG trials. This has been focused primarily right now, the idea on breast, colorectal, and prostate cancer. This could be expanded out to other obesity-related cancers as well, but we chose to use as kind of the initial concept. And this would look at longitudinal weight and height data after diagnosis, and we would then describe weight trajectories post-diagnosis, evaluate predictors related to those changes, and then we would look at the association between the weight trajectories and overall and progression-free survival. Some of the hypotheses are also listed here where we might see different trajectories by some of the characteristics, both clinical as well as sociodemographic. And then we had hypothesized that the weight trajectories of weight gain might be associated with poorer survival for early stage disease, but actually improved survival for those patients of advanced stage disease at diagnosis. Next, please. This is just a rough evaluation of sort of what we would be thinking about for sample size. We had looked at the work of Heather Greenlee, who had done an analysis in SWOG trials of BMI at baseline, so that at diagnosis measure, and looking at the studies that she was able to include in that publication from 2016. This is just a rough approximation of what we thought would be potentially available. And then the other kind of characteristics of these trials that we would be hoping to include are listed there. Next, please. And then in conjunction with that first project, I was also hoping to propose a second project, which would essentially try to launch a new pilot prospective cohort. So this would enroll individuals into a cohort that's not related to intervention. This would simply be following them forward. This is focused on initially breast cancer patients, and we were proposing to conduct this in 5 SWOGs institutions to get a sense of the feasibility of collecting stool and blood from these newly diagnosed patients at several time points. So at baseline, at their diagnosis, post-treatment, and then at 1 year. We were then hoping to be able to evaluate changes over this time period in the gut microbiome, the serum metabolome, and epigenetic age. And some of the hypotheses are listed there. I just don't want to take too much time, and then I can just briefly do the last slide, please. So we're hoping that this project could add to the emerging literature on longitudinal weight changes after diagnosis. And if we have this greater understanding of weight trajectories in relation to survival, it might help to facilitate some of our existing lifestyle intervention research to expand and target different populations than we might be targeting right now, and perhaps identify those who have the greatest need for weight management or weight loss. That's all I had prepared.
Great. Thank you, Dr. Ferrucci. I know that Heather Greenlee just posted something in the chat, and I encourage others to use the chat function. It's a great opportunity to be able to pose questions and comments. I like how you have two aims, one that's using existing data and then one that's a new sort of prospective analysis. And I think to make it clear that the collection of stool and blood would be done by the investigators, not by the institutions, because you would utilize FedEx or some other mailing opportunities, right?
Correct. We were exploring options where people didn't necessarily need to be in that clinical settings just to facilitate the easiest collection of those biological samples. So yes, I was seeing the comment from Heather here. We had not been able to confirm information yet about that having the follow-up BMI. So I guess maybe you are learning from your work, Heather, that you did not have follow-up BMI data. So that is something that we're definitely still exploring. If you had additional information on that, maybe I can chat with you offline.
Great. Thank you so much, Leah. Look forward to learning more. I'll pass it to you, Hallie, for the next talk.
Okay, yeah, and if anybody has other thoughts or suggestions for any of these, and you need to, Melinda and I are happy to facilitate connections since we don't have a whole lot of time in the meeting today, but thank you for that interesting concept. And the next slide, please. Our next presenter is Christine Duffy, who has looking into a concept regarding caregiver experiences. So Christine, thank you.
And so this is coming out of some research at the Lifespan Cancer Institute. Next slide. Next slide.
There you go.
Sorry. So Ozer and Young at the LCI interviewed caregivers about their experience caring for their loved ones with cancer. And then a companion assessment was done on people with cancer using the NCCN Survivorship Survey, which I'm sure you're familiar with. Next slide. So this was 24 patient caregiver dyads. They were 6 months out or longer from treatment. And this group was curative intent without evidence of advanced or metastatic disease. Caregivers participated in a semi-structured interview using an adaptation of the VA caregiver self-assessment worksheet, and it was supplemented by open-ended questions. And there were descriptive statistics. Categorical variables were compared using chi-square Fisher's exact test. Next slide. So just the basic demographics, the average age of the patients was 70, the caregivers were 66, and the gender was predominantly male, 70%. But if you go to the next slide, I'll explain why that is. Next slide. Sorry. It was predominantly breast, ovarian, and GYN cancers. They were predominantly early stage, about 2/3, and about 2/3 had received chemotherapy, and all had received some sort of surgery. Next slide. And this is the NCCN Survivorship Survey results from the patients who had cancer. So they were reporting about a little over 1/3, almost 40% of patients were having fatigue, which interfered with activity, and almost 40% were having sleep symptoms. 12.5% having excessive sleepiness. And then in terms of healthy habits, only about 2/3 were having any regular physical activity. And that was a very low bar. That was at any physical activity. Next slide. So this is the caregiver results. And the Likert scale was 1 to 5. And it basically, the 4 and 5 were considered to be people were functioning well. And so this is broken into 3 years or less and more than 3 years, and also the total on the right. So you can see that there's an improvement somewhat over time in terms of, say, getting rest and sleep, but it's still very prevalent at 3 years out. And similarly, in terms of handling stress, it's improved, but there's still a significant amount of people who are having stress, even 3 years out. And then staying healthy mentally and physically. You know, overall, almost 70% of people said that they were doing well, but 30% really still struggling, and particularly early on in the first 3 years. Next slide. So what did we learn? Caregivers continue to have needs after treatment is completed, especially around rest, sleep, stress management, and staying healthy mentally and physically. And these specific areas are also identified by those who they cared for. Next slide. So question, can we target an intervention to caregivers to improve the quality of life in the person with cancer they are caring for? Next slide. So this came out of, there's an NIH RFA, intervening with cancer caregivers to improve patient health outcomes and optimize healthcare utilization. It's an intervention, it's applications for intervention research, and the outcomes of the interventions are expected to optimize patient healthcare utilization, 2, importantly, improve caregiver well-being, and 3, improve patient physical health and psychosocial outcomes. Next slide. So just a little bit about exercise and sleep, because Dawn and I have talked about it. It's a common complaint in my survivorship clinic, and we know that there's a relationship, both exercise and sleep, and we know that there's a relationship between exercise and sleep. So exercising regularly seems to help with sleep latency and quality, and exercise obviously has effects on depressive symptoms, cardiovascular health, and even risk recurrence. Health, which are interventions delivered via personal mobile devices and wearable technology, can increase levels of physical activity in cancer patients and improve sleep quality. Cuthbert did an exercise intervention among cancer caregivers. This was not via personal mobile device, and it did show a small improvement in sleep-related outcomes on the Pittsburgh Sleep Quality Index, but it was a highly labor-intensive intervention. It did not include any apps or any M health. And you know, we also thought perhaps the dyad, that the dyad could provide an opportunity to improve the health and well-being of both caregiver and cancer patient, because there's evidence that there's concordance between sleep, between caregivers and cancer patients, and also that there's a relationship between the quality of life of cancer caregivers and the quality of care that cancer patients receive. Next slide. So this is the phase 2 evaluation of the Oura Ring, specifically the activity score, as an intervention to improve activity and sleep among caregivers and their loved ones treated for cancer. Next slide. So 50 dyads of people with cancer and their caregivers. The idea would be the caregiver is the primary person, and we would screen for insufficient activity with something like the Leisure Score Index, and also screen for sleep with the Pittsburgh Sleep Quality Index with a score of 5 or above. And for the persons in cancer, this is also one of our questions, using the NCCN survivorship survey responses, which people will be asking them potentially anyway, who screen positive for fatigue or sleep issues, and don't exercise regularly. And then computer or smartphone access. Next slide. This is just an overview of what the Oura Ring is. It's a multisensory wellness companion. It's actually a ring that looks a lot like a wedding ring, actually. It quantifies daily physical activity, nighttime sleep duration, and estimates sleep stages. And it does provide a sleep quality score. It has the ability to track cardiovascular outcomes and sleep outcomes, and they have the sleep outcomes have been compared to the gold standard, which is polysomnography. It does provide an activity score, which is a balance between activity and rest. And they have optimal, good, and struggling below 70. And there's also an app that also provides a lot of additional information to people. Next slide. So people would obviously need to learn how to use the Oura Ring. We would also want to give people general cognitive behavioral sleep recommendations and recommendations for physical activity, and then monthly questionnaires of both caregivers and the person with cancer, the Pittsburgh Sleep Quality Index, the Leisure Index, anxiety, depression, and quality of life, and other things, but thinking about not overburdening patients. Next slide. So for discussion, we actually had a number of things this is obviously in the very, very early stages. One is obviously the cost of the Aura Ring. Could we get it at research cost? Would we give the Aura Ring to both caregiver and survivor, or would we just give it to the caregiver and measure outcomes in both the caregiver and survivor? And would we recruit all cancers or limit? Would we do it? Would we say 1 year out? Would we say 6 months? Would we say as soon as they completed treatment? One big question we have is the feasibility to screen on 2 criteria, activity and sleep, not just with the caregivers, but with the patients, and any interest in the proposal and people's thoughts about mechanism, R21 individual institution versus SWOG. So any comments or thoughts, welcome.
Thank you, Dr. Duffy. I think if a proposal's eligibility doesn't limit to a certain cancer type, such as breast, I think better to propose including other cancers. You could target something more like whether it be metastatic cancer and then include various cancers or something. But if you don't need to limit to a cancer type, I personally wouldn't.
Open it to all, yeah.
I would agree. And then, so the intervention to improve sleep is what?
Is actually the Aura Ring is the physical activities, like giving people feedback on physical activity and sleep. And this is something that Dawn and I talked about. Should the intervention be, what exactly is the intervention? And really what we're trying to do is give this the Aura Ring, this wearable device, and see if it can improve outcomes in physical activity and sleep. I think we would be focusing on physical activity, but with the hope it would also improve sleep.
It seems like you would need to give the participants a physical activity target or
yep.
something to, so that they say, okay, well, I don't know what this number means, so I'm not changing my behavior.
Yeah, it does give them an activity score that we could definitely ask them to meet a particular activity score. We plan to give them general physical recommendations for like what's healthy activity, and then give them goals for the activity score.
I can't recall when the due date is for this RFA, but we would love to review a one-page concept.
I believe it's rolling, and it's like there's still another year on the RFA.
Okay,
I think.
great.
And Don, you correct me if I'm wrong, but I'm pretty sure. So just some of the questions. Have other devices that measured physical activity and sleep quality been shown to impact activity and/or sleep levels? Yes, there have been a couple studies, but the one that I mentioned in the previous slide, it actually was a physical activity. I'm sorry, not that one. It was there have been several, and I cut the slide out, but I did have slides on stuff for physical activity and for sleep. I think the sleep has always been really a secondary outcome based on physical activity. So I don't know if that answers. And I think someone also asked, how does the wearer get feedback from the Aura Ring? There's an app, and if that actually gives them feedback.
Yeah, hi, it's Dawn. Can you hear me real quick, and I can just give some further context on this. So I think this builds on two things that we've talked about in digital engagement and digital health. The first being, is the intervention the instrument, or is the instrument a tool towards another intervention, right? So here we're actually could actually test some passive receipt of information on health activity and how to get good sleep. But the intervention itself would be that the user could track their scores on a daily basis using the companion app. And quite frankly, based on very personal experience, and I'm not paid by Aura at all, I actually do use the app to see what my activity and sleep scores are. And I actually do seem to be trying to improve them. So I do think that things like this, the wearable sensors, the Fitbits, they can actually self-motivate to do something better. But I do think it would be impossible to give someone a tool without subsequent help, or, you know, in symptom and quality of life, we just talked about coaching, right, on how to actually improve things going forward.
Great. I think we'll have others post any questions in the chat just to move on, but we look forward to learning more about your concept.
Thank you.
Thanks.
Next slide. Okay, an exciting proposal now being presented by Dr. Raz and Son. If you want to, Dan, I think you're presenting it.
Yep. Hi, all. I'm Dan Raz. I am a thoracic surgeon at City of Hope, and Virginia, who's also on the line, is the co-chair of this study that we're developing. I think most of you know Virginia. So our concept is a perioperative physical activity intervention in older adults with lung cancer who are going to be having lung cancer surgery. Next slide. I feel like Dr. Alfano's talk was a really great setup for this. We have a huge number of older adults who are having lung surgery. In fact, the average age for patients undergoing lung surgery is about 70. So, you know, I'm regularly operating on patients in their late 70s, 80s, even early 90s. And these patients obviously are very heterogeneous, and we know that, you know, declines in physiologic reserve can cause longer lasting functional impairments after surgery. And we have a number of challenges in addition to the growing number of older adults with lung cancer. We're also just in general discharging patients early. So for example, at our institution after lung surgery, the average length of stay is just 2 days. And sometimes we send patients home 1 day after minimally invasive lobectomy. We have huge pressures to reduce readmissions. And so the burden of care falls upon the patients themselves in this self-management concept, and also on family caregivers. And this caregiving role can really lead to deteriorations in family caregiver well-being. So we know that physical activity does help getting patients up and walking after lung surgery, after other surgeries, after, you know, in general is good for you. But there are a lot of issues with actually implementing this in a structured way where patients and family caregivers can really, you know, stay active and get some guidance. Next slide, please. So as I mentioned, we know that getting patients up and walking helps in a variety of settings, including before and after lung surgery. Some of the limitations of published studies are that very few focus on older adults, and I'm talking about specifically for surgical studies. Most of these focus on exercise that's administered, you know, by a physical therapist, but there's really not an emphasis on self-monitoring or self-efficacy. There's really no family caregiver aspect. There's a lot of variation and adherence between these different studies, and very few of them are really integrating behavior change framework, which Virginia has really nicely done in this study. Next slide. So for this study, our primary objective is a change in functional capacity, and our primary outcome is 6-minute walk test. But we're also looking at the SPPB at 30 days after discharge from lung cancer surgery. We're also looking at patient and family caregiver self-efficacy scores at day 30 and day 60 after discharge, patient and family caregiver self-reported physical function, patient quality of life, patient time at home, surgical complications, readmissions, sarcopenia based on standard of care CT scan muscle measurements. And we're also, we have linked up with Bill Evans to include the D3 creatinine analysis to better quantify changes in muscle mass. And we're also looking at digital biomarkers as well as blood biomarkers of aging as exploratory objectives. Next slide. Next slide. I think this is the, yeah, you can just advance until they're all there. So as I was mentioning, so we included intervention framework. So the chronic care self-management model, so proactive planning and self-efficacy, principles of complex behavior change. And we utilize these frameworks to develop the intervention. And basically we, in the preoperative setting, do a geriatric assessment, timed up and go, 6-minute walk test, kind of a full functional baseline assessment. Physical therapy and occupational therapy actually centrally administered. So all of this will be done via telephone through physical therapy and occupational therapy. And then there's 4 coaching sessions, which are done via Zoom or telephone, as well as some print materials. And basically we develop a personalized walking program. So based on the initial assessment, the geriatric and functional assessment, we develop a walking program. There are some other aspects, lower extremity exercises, safety precautions, and then we do provide a pedometer. So we've chosen the VivoFit 4 because it's inexpensive. The battery lasts like forever, meaning the patients don't need to charge it every day. It lasts for, I believe, a year, and they're very durable. And this allows the patients, the participants, to monitor how many steps did I walk today and kind of set goals and adhere to it that way. And then the family caregivers are primarily trained as coaches for the patients for the physical activity intervention. Next line, next slide. And during the actual calls, the patient gets motivational interviewing at the baseline, goal setting, planning, defining and overcoming challenges. They get the personalized walking program as well as some lower extremity exercises. The caregiver is trained as a coach for their loved one. They're given strategies for social support, and we also monitor the family caregiver's physical activity and quality of life. And then both get a resource manual, kind of summarizing all of the information and the importance of staying active, kind of some safety precautions, and just other lung cancer kind of specific information. Next slide. And this is the study schema. So we're looking to enroll patients 70 and older who are scheduled for surgery. We want to make this as feasible as possible for sites. And so oftentimes there's very short kind of intervals between someone scheduling surgery and actually having surgery. And so we are looking to have patients get enrolled at least 14 days pre-op. This says 7 to 14, but it's probably going to be 14 days pre-op. We are developing this in English as well as Spanish speaking. So that's a addition since the last time we presented this concept. And they have to have a family caregiver, either family or friends, someone who's going to be available to participate in their care when they get home, who's over 18 and English or Spanish speaking. The patients will be then randomized to either the intervention, which includes the coaching that we described, the personalized exercise program, the intervention, they get the pedometer, and then the usual care, they will still get the pedometer as well as a more limited physical activity literature for them to use as a guide. And then we're going to be assessing patients at 30 and 60 days. Next slide. as we presented before, we did do a pilot study of this intervention.
So Dan, we're going to ask you not to be repetitive because we have a few
Okay,
more
yeah.
concepts to present. So if you could just sum up, that would be awesome.
Yeah, I think that's kind of the bottom line. This is something for patients and family caregivers to get them up and walking in a personalized manner that hopefully improves functional outcomes for older adults after lung surgery. So I'd love to kind of get any questions if we have time for that. Otherwise, we can communicate offline.
Oh, you're on mute, Hallie. I would encourage people to post comments and questions in the chat. I love some of the innovative aspects of this and how you've changed the eligibility or broadened it to include Spanish-speaking individuals. So thank you, Dr. Raz.
And this is incredible. And I think the next slide, I was going to say, I think has just kind of maybe the one after that. I like how maybe the one after that. That's good. There, that you're
okay.
Kind of showing us your progress, and I love that. We should have that as a standard for all of our presentations to see where we are in the development. So that's terrific.
Thank you.
All right, and then Dr. Carter, I'm also going to ask you to be very brief. Thank you for logging in. We can go to the next slide. I believe this was actually presented already today at the Symptom Control Committee. So if you could just kind of share the main idea, we can go to the next slide, and I'll have you go ahead and share very briefly this concept. Thank you.
Yeah, thank you so much, and thank you for letting us present here as well, so we can rally the community. But a great point made. This was presented already. The goal of this is we are interested in, we hope you are as well, in identifying a risk prediction model for immune-related adverse events from immune checkpoint inhibitors, ICIs, in solid tumors. Next slide, please. So our primary goal, we've done risk prediction model before. You may know our Corona score. We helped guide Dr. Corona was a first year faculty to use our cohort study for febrile neutropenia risk modeling, for the Corona score, for cancer-associated thrombosis risk modeling. We've done some COVID work, and now with Krishna as the main lead and a wonderful multidisciplinary team to develop and validate a risk prediction model for non-hematologic grade 3 or higher immune-related adverse events in the first year of ICI therapy in solid tumors. Next slide. Our secondary goals, and maybe I'll keep that even brief, it's really longitudinal toxicity assessment, as well as quality of life, and PRO are a big part of this. Great team here with Lynn and Mike to help us with that, and get the tox score, the longitudinal tox score, including low-grade toxicities for that. In order to get at some of these more chronic toxicities that have been really poorly described as well, and track patterns of treatments for IRAEs, as well as toxicity resolution. We're really excited also about a very small but targeted longitudinal translational objective. The primary goal was here to look at the cytox score, to look at these 11 cytokines that have been suggested, and see can we independently validate those. But more importantly, or as importantly, this will be a rich biorepository available for SWOG, for archival tissue, as well as especially serum and buffy coat, as a few others, blood, on a small longitudinal scale. Next slide. So it's about chronic toxicities and PROs. Next slide. So just briefly, eligibility is standard ICI therapy, so it won't compete with existing trials. These are our real-world standard of care patients on mono or combination ICI therapy, so we will not allow any combination with any other cancer therapy or other therapeutic clinical trial. They could be on supportive care trials, but not intervention trials. They can have prior ICI therapy, but they must not have discontinued that due to an IRAE. Obviously, they have to complete PROs, and we have multiple languages available, and should be reasonably recovered per treating physician. Next slide. So I won't belabor these. Please be in contact with the baseline risk factors are that we will be looking at. And we might be a little bit fine tuning still here as we'd like to be up to date on what is coming along, both on demographic and historical factors, PRO and laboratory factors as well. Will be looked at as a predictor for future IRAE development. Please be in touch if you have anything that you think is very pertinent that we've missed or that's coming along that you've seen early phase data. Please let us know. Next slide. Our accrual goal is over 2,000 patients. That's why we kept it very parsimonious. So this will only be 5 visits. We hope this should be very doable for the community and is hopefully a wonderful trial for patients that are not who are on standard of care, and a wonderful team effort. Also with Krishna is our main lead. We've all helped her along on various aspects. Dawn has been our fearless leader to help us get a large non-randomized cohort study through SWOG, which has been very eye-opening and to help minimize as much as we need to, but really have still a very exciting translational prospective study. Do I have, no, I don't think I have any other slide. I think this was a reduced. For patients, we are hoping to risk stratify. We hope to find the vulnerable patients that will hopefully enhance not only clinical decision making, but also monitoring and hopefully ultimately lead to better outcomes for these vulnerable patients, as well as hopefully also lead to better trials to really treat these toxicities.
Thank you so much, Nicole. It's exciting to see the progress on this concept. I remember the idea of it was introduced a good couple of years ago, so excited to see it moving forward. If people have any comments or questions, please put them into the chat box, or you can either email them directly to Krishna and Nicole or to us, and we can forward it to them as well. And I think we have one final concept tally, right? By Vicky Barakos. And I know, Dr. Barakos, you have, this concept has been approved. And so perhaps given the limited time, if we just focus on the status of the concept and any questions you might have and how to move it forward to the 10-page proposal.
2 minutes.
Sure.
This is a description of how a previously conducted SWOG trial could inform the study of cancer cachexia. Next slide. That's about muscle and how muscle is associated with poor outcomes in cancer cachexia. Next slide. Purpose is to understand, using this data, how tumor response, inflammation, and endocrine differences could drive cancer cachexia. Next slide. We can measure, and maybe others are very interested also in these measurements, which we do as our day-to-day activity. You can measure muscle mass change over time in oncologic images. These are 3 patients who've lost lots of body fat mass. I'd like to point out that on the right that you can come up analyzing diagnostic images from cancer clinical trials, a muscle change over time, which is very, very precisely measured and gives you a continuous distribution. And you can interpret that. It goes all the way from gainers, no changers, moderate, mild to very severe muscle losers. In the next slide, how we would do that with SWOG S081 by analyzing the CT images that span the first 2 cycles of ABVD, we could come up with this continuous distribution. There's 336 patients who fit that. Who fit that. I'm going to go to the last slide, which would have then the primary outcome, linear regression analysis to evaluate the association between that change in muscle and the things we believe are the etiological factors: tumor burden, treatment response, sex and baseline sex hormone, and inflammatory parameters. So what we're, present status of this project is I'm in communication over the full proposal with SWOG statisticians. and hope we can work out the finalized statistical plan as part of the overall full proposal, which is otherwise fleshed out. Thank you so much.
Thank you, Vicki. Just one quick question in the role of BMI as either an effect modifier or covariate, given that those with high BMI can also have muscle loss and those with low BMI as well.
So in fact, when you take weight, body weight of BMI, it has two pieces, lean, well, maybe three pieces, but for purposes of that discussion, its major constituents are fat and muscle. So body weight, muscle weight, and fat weight are intercorrelated, highly intercorrelated. So what you would probably use to answer your question in this analysis is the covariate wouldn't be BMI, which includes muscle, but rather fat mass, which is derived from the scans.
Thank you so much. I think this is a really clinically important concept, and we look forward to your fuller proposal so this analysis can be done. Thank you.
Yeah, this is also so much about imaging, CT imaging sarcopenia in the chat. So if I could join forces with others on that point, it would be just great. Thank you.
This is a really great example of using a completed study to look at an important survivorship issue. So thank you for sharing that. And then the last concept was an update on the AYA ovarian protection study, and I'll save that for our next monthly meeting by telephone. Our apologies for going over. This is a habit of ours, but thank you all for sticking it out. And please feel free to share via email any questions, comments. And also, I think we will try to have our monthly meeting in May so that we can continue to move forward on some of these exciting ideas.
Thank you, everyone.
Have a good afternoon, evening, depending on where you are.
Thank you.
Bye.